Good afternoon, everyone. Known as the graveyard session immediately after lunch is always a tough one to take on. Given the session's about people, I'm going to start with a story about people. So I've been living in Kenya since 2012 and just very recently moved back. In the last 2 weeks whilst I was there, these two ladies were in one of our outreach clinics that we went to. They were both in their 70s or 80s, hard to determine their exact age. They'd been friends for years, but actually hadn't seen each other for the last 10 years, and that's because they were both blind. And they used to be spending all their time together. And this is the moment that they actually realised they were sat next to each other, because we called their names to come on the bus to take them to the hospital for surgery. And it was a sudden realisation that even though they'd been together for the last 2 hours, that they were there with one another. And from that point on, they held on to each other through the whole process, from being picked up to surgery and seeing again. And this is them shortly after their surgery, and we'll come back to them later on. There are 39 million people in the world who are like this, who are blind. 80%, so 4 out of every 5 people who are blind from conditions that they don't need to be blind from. So conditions that we can either cure or we can prevent people going blind from if we detect them early. And if you look at where blind people in the world live, they're predominantly in low-income countries, which is in stark contrast, known as the inverse care law, to where eye doctors are who can provide treatment. So you can see most of us are based in the Americas and in Europe, and the greatest disparities in sub-Saharan Africa between the level of need and the people able to deliver it. And just to give you an idea of the difference, for every one eye surgeon in Kenya, there's approximately another 100 in the UK. So that's the kind of disparity that we're talking about. This disparity is compounded that within the country, the very few eye surgeons that there are, so there are 86 in the whole of Kenya, half of them live and work in the capital city, Nairobi, which only is 8% of the population of Kenya. So as you go out to the more rural areas, where there are more and more blind people, there are fewer and fewer people able to access them and provide treatment. So there's lots of issues. There's a lack of human resources, there's a lack of infrastructure, but the bottom line is that those in most need are the least likely to access eye care. So with this in mind, we set up a 6-year cohort study, which is where we took 5,000 people in 2007, and we followed them up over 6 years. We set up 100 eye clinics in remote areas, such as this one, often using schools, churches, the village chief's hut, whatever it was needed to run very comprehensive eye examinations to try and understand why people were going blind. The locations were often very difficult to reach, so very beautiful, as you can see here, but if you look closely, there's no road anywhere near it. So the point where this photo is taken from is where we had to park, and then we had to walk an hour and a half carrying all of our equipment to this clinic to set it up. And when there are roads, they're often very difficult to use, and we spent a lot of our time pulling our vehicles out of roads when they existed. We used state-of-the-art equipment, so the kind of stuff you'd expect in a top NHS or private practice eye clinic here, to be able to provide very comprehensive eye examinations. But again, even when we did get there, power supply was very intermittent if it was available at all. So we ran most of our clinics using a petrol-powered generator, or converted the minibus into effectively a generator. So in total, we had over £100,000 worth of equipment to go and do the kind of examinations that were needed to answer the questions we were after, and a team of 15 people, all local Kenyan guys that we trained up to be able to do all the tests. Now, there are so many challenges to doing this kind of work, which is why very few people have done it, and it's why this has never actually been done in sub-Saharan Africa before. So this is the first study of its kind. And it dawned on me there had to be a better way of doing this. Now that's the Nokia theme tune. Now this, I don't know how well you can see that, but that's a pit latrine in the middle of nowhere where we ran one of our clinics. So there was no water here, there was no electricity here, but as I went to this toilet, someone was sat inside on their Nokia mobile phone. And it just struck me, this is the situation. There's no water here, but everyone has access to a phone, and we can discuss the hygiene issues of them using it in a pit latrine later, but it really struck me that where there is no access to everything else, everyone still has a phone. And phones, in terms of their capabilities, are becoming incredibly powerful. So this is the computer that put a man on the moon in 1969, and it filled a room 3 or 4 times the size of this. It is magnitudes less powerful than a modern-day smartphone, which pretty much everyone will be walking around with in their pocket. And we reached 7 billion people on the planet a couple of years ago, of whom nearly all of them were connected via mobile phone. And we're soon going to get to that point of ubiquity where everyone has at least at least someone in their surrounds that has connection via mobile. So that's more people with access to mobile than clean running water. And in Kenya, 80% of people have access to a phone, 50% have access to water. And as mobile phones have evolved, we've thought, is there a way that we can harness this technology to deliver eye care in a new way to those who are the most underserved? And that's where we came up with FWIC, the portable eye examination kit. We went about transforming all the existing high-tech tests that we had in the clinic to mobile applications. The first one being a vision test, and you can see here people being tested in their homes. And it was really about building this in Kenya. We didn't build this here and then take it. We built it in Kenya, and we learned from the people who are using it. So the people delivering the tests, the patients who are being tested. So this vision test can be done in any language at almost any age. And we've built in lots of gestures. So you can see here, as the lady points, the direction of this letter E changes. And the tester just swipes the direction the patient said. So he doesn't actually need to know if she's giving a right or wrong answer. We built in gestures, if she can't see, she shakes her hand. So you just shake the phone, it records that she couldn't see it. And so really kind of building in the user experience. And on the front of your phone, you have something that adjusts the brightness of the screen. We're tapping into that so that we can look at the science and see at what point are you getting inaccurate measures if it's too bright. And so the phone tells you if this is not going to be an accurate test. The results are then recorded on the phone. You can then share it, display it in various different ways. And we're using it in lots of different places. We've got a pilot project going in 30 schools in Kenya where we're empowering teachers to find children who are visually impaired. It then sends an SMS to the parents and the teachers and a referral to the hospital automatically, sends them auto messages back if they haven't turned up after a period of time. And in terms of it being person-focused, if I give you a result of you've got 660 vision, if you're not in my profession or in healthcare, that doesn't really mean anything to you. But if I show you what your vision is, or I can show you what your child's vision is, then it actually means something, and that can happen immediately after the test. It can be emailed as a picture from the school saying, this is why your child's struggling. And we found it really important to be able to share this information in a way that is meaningful. We're also developing tests for very, very young children. So this is one of my co-founders' child who probably got an eye test at 0 hours old. And it's using eye tracking technology, which is going to soon be standard in all mobile phones. And what it's doing is watching where she's looking on the screen, and the targets are getting more difficult and difficult to see. And this way we can actually see what the vision is from a very young age. And the cost of something like this is magnitudes lower than the existing card-based tests that are standard practice. Same for visual fields. I don't know if any of you have had a visual field test where it tests your peripheral vision, and this is an important measure for things such as glaucoma. We're trying to make it more like a game or something that's more intuitive. So you just follow this target, and it's looking to where you've seen a target in your peripheral vision. And if you've seen it, it marks it as seen, and then gives you information that we can then use. The next really important thing for us was, if we've determined your vision's poor, we need to know why it's poor. And the secret to that is being able to look inside the eye. So this is the retina, the back of somebody's eye, and this really carries a wealth of information about somebody's eye health as well as general health. You can diagnose conditions such as diabetes, high blood pressure, malaria, HIV. All of these things can be picked up by seeing the retina. Now, some of you will have been to the optician and had this kind of experience where you've got someone intimately up in your face, shining a bright light, trying to work out what they can see. And you ask most doctors, and we call it the guessing stick, because although it's a 100-year-old technology, it doesn't work very well. You can't share what you've seen. You have to draw pictures of it, and it's still fairly expensive for what it does. The alternative is a very high-tech camera, like the one we took to Kenya, which costs £20,000 to £30,000, requires a stable power supply, and generally isn't designed to move around. So we went for something in between, and we, using 3D printing technology, built a purpose-built add-on to a smartphone which turns it into a retinal camera. So I'm sure most of you are familiar with 3D printing, but effectively what it allowed us to do was do some rapid prototyping, make designs, see how they work, change them, print them again, and very quickly build up a unit at very low cost that we can now clip onto the smartphone, and it allows us to get views inside the eye. And the beauty of this is it's as easy to use as it is to use a mobile phone to take a picture. You don't need to have any experience. So my mother can now view the inside of my eye without any training. Here it is clipped onto the back of a phone, and this is the kind of views we're getting inside of the eye when using it. So what we're seeing there is that's the optic nerve, which is a direct extension of the brain, and then moving out into the peripheral areas of the retina along the blood vessels. And this is it being used in Kenya in patients' homes. And we're also using image stitching technology, which allows us to take lots of images, and what you can see here going on is it automatically captures when images are in focus, and then it can use the blood vessel arcade to stitch pictures together so that we know we're creating a wide field image, which would normally only be possible with very expensive optics, but we're using software to overcome these issues. So now the idea is we go to the patient, we don't wait for them not to come to us, and we examine them in their own homes. We provide comprehensive examinations, and what's more, we test everything that we've done. So that trial I showed you earlier where I was going around setting up 100 clinics, each of those patients was also tested with PEAK in their own home, so we've got data to compare this to and say, well, is it really working? Every time an examination takes place and the user puts their details in, put the patient's details, phone number, etc., what you see here is this little thing flashing in the corner, and that's the GPS. So that's marking exactly where that examination is happening. So every patient record that is created is GPS-based. And the reason this is so important is most of the people we're dealing with did not have an address. And what's more, their names change. So they become their mama or papa, the name of one of their children. And the name of that child might change depending on which day of the week you're speaking to them and who they're favourable with. So if you're trying to track someone down who doesn't have an address, doesn't know the year of birth, and you don't know their name, it's incredibly difficult if you need to provide follow-up treatment. So giving somebody a GPS suddenly makes this person someone who's then contactable. And given that nearly everyone has access at least to a mobile phone, they become someone who you can ensure gets treatment. And so in the back end of this, we're working with a team called OpenEyes, and we're effectively developing a way in which you can search by any of the parameters, any of the examinations you've measured. So here we have people who are blind in one eye from cataract, hover over the red pin, and that's somebody who's contactable, traceable, and treatable. What we learned from working in the system there was really important to be able to communicate effectively with them. And so we can send a text message to those group of people saying that we're coming, but sending a text message to people who can't see is not always very helpful. And so we have the person we'd call a key informant. So that would normally be the community healthcare worker, or it might be the priest in the area, some kind of village chief who's a designated person who is also going to get a list of the people who you're going to come and collect. And they're your kind of go-to person who'll go and they'll get everyone ready and they'll bring them for treatment. We've overcome the issues of power supply by taking a solar-powered rucksack, and that charges the backup battery. So initially I was asking all our healthcare workers to stick the phone in the bag to charge it between patients, and I'd come back and they'd only done half the examinations, and that's because it's still gone dead. And what I realised is people want to keep phones in their pocket. So rather than telling them to change their habits, we try and build on their habits. So we got a backup battery, which we put in there, and we charge it, and we make sure all our phones have got replaceable backs so that we can just flip it off when it's finished and put a new battery in. And that way people are using phones in the way they want to use them. If we try and change natural behaviours, you're unlikely to succeed in what you're trying to achieve. So we hope for no more scenes like this where we're stuck on the way to try and provide this kind of system. And we're now able to connect people all over the world. So this is a patient in a rural clinic in Kenya having their images read by an expert grader at Moorfields Eye Hospital in London. All of the images, all of the data that we collected using PEAK was compared against the standards, the kind of equipment that you'd expect in a UK hospital. We've now got data on 2,500 people comparing one with the other. So this was the two ladies that were friends, and this is this lady when we took her home, seeing her husband for the first time in about 10 years. She was commenting on how handsome he was, but also how old he'd become. This whole project has been a collaborative effort. There's been some great people involved in what we've been doing. Stuart, the software engineer, Mario, hardware engineer, Ian, paediatrician, paediatric ophthalmologist who was testing his baby at 0 hours old, Matthew and Hannah, my PhD supervisors and mentors, and Tunde at Moorfields Eye Hospital. Huge team in Kenya who really made it all possible, and my wife and son who made many sacrifices to come and live in Kenya whilst we did the work. And a thank you to our funders and partners, and now the Queen Elizabeth Diamond Jubilee Trust who've funded us to carry on doing this work for the next 5 years. And so we've got plans to do work in Kenya, Tanzania, Mali, India and Botswana now. And I'm just going to end by just showing you a short video which just sums up the project in 3 minutes.
do we have any questions?
Absolutely amazing. Brilliant presentation and a great story. So thank you very much. A couple of questions. One about medical device and working with the UK hospital and whether it's an approved medical device, but possibly less than that. Interested in your insight into actually operating a mobile phone app in Africa.
Mm-hmm.
So I've just been asked to do something at work in this area. I look on the internet and it says data capacity is going up and more people have got mobile phones, but it still seems as if SMS is the only ubiquitous communication method.
Mm-hmm.
On the ground, is it SMS or are you starting to see more capability being available to using your apps?
Kenya's probably a bit ahead of the curve in Africa, but it's still very much your kind of first, second generation SMS-based mobile phones, which is fine in terms of what we're trying to do, because we don't need the end user or the end recipient, as in the patient, to have a smartphone. We just need someone in their community to have a connected device, and that an SMS is sufficient. What we require is a healthcare worker who has to be integrated into an existing health system. So what we don't want to do is supply this to anyone, but if there's no one at the end to provide treatment, then the technology is useless. So it has to be built into an existing health system. So we work with the Ministry of Health in Kenya, we work with NGOs to make sure this is part of a package that is resulting in someone being enabled to get treatment at the end. And in terms of, one of the studies that we did within the larger study was comparing an eye healthcare worker who had lots of experience in eye care and someone who was just a geek with smartphones and liked playing with mobile phones but had no background in health, to see how the two would compare against one another. And what we found is they're entirely comparable in terms of the quality of data they were collecting. And that's partly in terms of how we built the applications and tests to be very much user experience focused in terms of what are the simplest ways you can deliver the test, what's the most intuitive response to the ways we're doing things. And so much of the lessons we've learned have been in terms of the problems we had on the ground and modifying it for those purposes.
So, gentlemen.
Dick Wallace, Position Systems. Did you find any cultural problems overcoming the advice of local village doctors who may be prejudiced against Western medicine? And did your advice go on to possible causes, dietary, lifestyle? Was that acceptable?
I think it's a really, really valid and important question. And so what we didn't do was go in and tell people how to use this technology or what they should do. We actually only worked with people who were already on the ground. So that person that you talked about would be our go-to person. They would be the person that we would go round with. They'd be the person that would take us door to door, would advise us where they thought people might be and where the examination would happen. So unless you had buy-in from that person, it was never going to work with whatever technology you had. It was all about finding your person who was going to be your guide, your champion in that community. So finding them was more important than the technology. The technology enabled us to do what we're doing through that person.
So, Nick first. And then
Maybe a follow-on question from the other one. When you're doing the examination, do you need a connection at that time, or are you effectively doing that just standalone and take the results away?
So the way our technology works is you don't need a data connection. It'll work without it. If you have a data connection there, then you can share information instantly. If not, as soon as you're in a position where you've got 3G or you're connected, it'll upload the data.
You've used this technology in Africa, and it's obviously a great advantage to the people there. Are there any plans to move this technology into the first and second world in remote communities, such as Scotland, the Highlands and the islands of Scotland, for example?
We actually have interest at the moment to do a project in the Highlands. There's a few regulatory things that we have to do in the UK first, which allow us, so things that there's the MHRA, and we're at the moment getting this CE classified as a medical device that we can use. So at the moment, through the Tropical School of Medicine where I work with, through our research partnerships, been able to do this within that setting. But to do it in the UK, there's some other things that we're working on doing. But interestingly, since this had some publicity, most of our interest has come from the US and Europe. People saying, yeah, there's people in the middle of nowhere in Kenya, but we've got people in the middle of nowhere here who struggle to get an eye examination, and we'd like to do that here. We've had interest from people working in accident and emergency, general practitioners who traditionally struggle to look and examine an eye efficiently. This will enable them and hopefully reduce costs within the NHS. We've had interest from vets as well. Lots of vets saying, can I use this on animals? And I say, well, in theory it should work. So yes, we do. The model that we're trying to build is one where we create revenue in high income settings, and we use that to subsidise or make a low cost version available in the kind of target areas that we're really interested in.
Gentleman in the back row.
So on the target area front, is the difficulty actually finding the people on the ground? Is that your biggest struggle?
Yeah, so and one of the questions I often get asked is, okay, great, you've got this technology, you're going to find loads more people. Who's going to treat them? And it's one of the misconceptions, although there's very few eye doctors there, their trouble is finding the patients. And what happens is, to find the patients, you need the people who know how to examine an eye to leave the hospital, go out into the community, examine people, make an assessment as to whether they've got a condition that's treatable, and then bring them back. But whilst they're not in the hospital, there's no one in the hospital treating anyone. So you've effectively halved your capacity. So what this does is it allows us to task shift. So it allows you to get people who don't have a medical background to go and do the legwork on the ground, go door to door, find people, do the very basic assessment first, and if their vision is low, go on to do the more rigorous tests, which are then interpreted back at base by the expert.
It's a job you're paying someone for, and that's where you're saying get it coming from. I mean, that's ultimately subsidised.
Yeah, I mean, at the moment we haven't rolled out to do that, but certainly there's interest from Safaricom, which is the big mobile network provider in Kenya, and there would be ways of incentivising people to do examinations and paying them for doing that. But there would have to be an effective business model which would enable everyone in the chain to benefit.
Or charity.
Yeah.
So, just one more quick question.
Have you seen interest from other medical fields? So saying, well, you've done that with optometry, could you be doing this with midwifery?
Yeah, we've had a lot of interest from varying fields, from ear, nose and throat to obstetrics and gynecology to teleradiology. And our plan is everything is going to be open source, so that if you can take this platform and then build, so we've built eye tests on a platform, you can build whatever tests you want on that platform. And we really want to encourage people to take it and use it and improve it and change it. And that's very much our hopes for it. But in terms of where my expertise is, it's within eye care. As somebody who wants to, I have a habit of not remembering faces, but when I look inside people's eyes, I remember who they were when I've seen them in the clinic. And they said, well, I'm really glad you're not a gynecologist. So I'll stick to my field.
Okay, thank you, Andrew.
All right.